and good afternoon to everyone joining from different countries and different regions. On behalf of the WHO Department of HIV, Hepatitis and STI, I want to welcome you all very warmly to the 6th session of the Dialogues for Viral Hepatitis Elimination. And just to remind us that it's a highly interactive session where public health officials, policymakers, program managers, clinicians meet to share experiences and lessons learned to enhance the vision of viral hepatitis elimination. My name is Dr. Fumi Leshi, and I'm joined by WHO colleagues here in Geneva, Nicholas, Diana, Sandy, as well as WHO colleagues from the various regions and countries of the world. Our topic today is on data, and we're talking about establishing data systems for collecting and managing routine viral hepatitis data. Next slide, please. I'll quickly go through our agenda for today, and we have Dr. Diana Finey, who will take us through the WHO guidance on person-centered data monitoring viral hepatitis. And our guest speaker from Ministry of Health of Rwanda, Dr. Janvier Serhundo, will share their experience on integrating hepatitis module in DHIS2 for reporting the cascade of care. And then we have our colleague from WHO IAC, Dr. Catherine Demartel, who will also share with us the recommended approaches to estimating hepatitis mortality. And I note here that it's so important to understand the range of viral hepatitis surveillance, which ranges from prevention, testing, and treatment, to also catching the mortality and morbidity associated with viral hepatitis. And we often do not remember that liver cirrhosis and liver cancer are important outcomes of viral hepatitis. And I just want to share with us one quick fact about viral hepatitis. And we know that globally, over 350 million people have viral hepatitis B and C, and 3,000 people die every day from the consequence of untreated viral infection. And that is 1.1 million people every year dying. Now, the elimination vision for mortality is less than 500,000 deaths per year. So there's a huge gap and there's a lot of work to be done. Continuing on the agenda, we have our colleagues from WHO EMRO region and Nicholas Luhmann and Sandy from HQ that will facilitate the questions and the answers and the comments. And we would wrap up very briefly with a closing remark. Next slide, please. So, brief housekeeping. I think we're all very familiar with these housekeeping rules. The interpretation in English and French is available, and we need to click on it and choose the language we would like to hear. The live transcript can be enabled by your clicking at the caption that highlights the transcription. We welcome and invite you to use the chat feature for questions, to engage the speakers, the presenters, and other participants regarding the topic and the presentation. And it will be an important tool for use during the Q&A session. Next slide, please. And also, please rename yourself. We would like to meet you. Please rename your Zoom ID to identify yourself. Put in your first name, your last name, and your country as shown on the slide. And just for your information, the session is being recorded, and the recording, the PowerPoint, and every resource will be shared with you after the webinar. And of course, we always appreciate our partners, Project ECHO, that support this platform. Next slide. And without further ado, I shall hand over to my colleague, and she would share with us the importance of monitoring of data and share insights about patient-centered data for monitoring of chronic viral hepatitis. So Dr. Diana Finey, over to you, and thank you and welcome.
Thank you, Fumi. As mentioned, my name is Diana Faini. I work here at the Department of HIV, Hepatitis and STI, responsible for hepatitis strategic information. And for these sessions, we'll be focusing on person-centered data and guidances from WHO in building systems that enhances this. Next slide. So my session of the presentation will just echo what Fumi alluded to earlier on the global health sector strategies, on the strategic directions related to the generation and the use of data for decision making. I will dive into the person-centered data monitoring guidances, health power strategies, and the stepwise recommendations from our department on building country surveillance. Then I'll briefly mention on the upcoming guidances on person-centered information systems for viral hepatitis. As you may well be aware that last year our department released the Global Health Sector Strategies 2022 to 2030, and the strategy outlined the need to generate and use data to drive decisions. Hence, countries are recommended and to have robust information system and the capacity in terms of infrastructures and staff to collect and manage and use this data. Particularly for hepatitis, this is necessarily for countries as they track their progress towards hepatitis eliminations. So within the document, 2 actions were outlined that included person-centered data for monitoring viral hepatitis, as well as investments in strengthening information systems for viral hepatitis. And particularly because of this year we'll be updating our strategic information guidelines to provide further guidances on these strategic actions. Of the actions that were stipulated in the guidance, it's important to understand that investments in strengthening information systems are needed for viral hepatitis, and this is particularly important because viral hepatitis needs to be integrated across broader health information systems. We understand that the systems for viral hepatitis are complex compared to those currently available for vertical programs in HIV, malaria, and TB, because we need to track and capture information of a person's across different lifetime, including looking at from acute infections, chronic infections, as well as sequelae that lead to morbidity and mortality for hepatitis. And this is very keen because it could take 20 to 30 years since one is diagnosed with hepatitis towards the sequelae that is attributable to hepatitis, and therefore a robust health system that captures information across health sectors is needed. And being mindful of other ongoing investment that are in, for instance, antenatal healthcare systems, the integrated health systems need to be in place to track efforts as well as to look at interventions of elimination of mother-to-child transmission of hepatitis, and see how data collected in these different platforms are linked together and provide information across the broader health system. So the integration is key across different sectors, immunization, HIV, STIs, where already we're seeing countries integrating hepatitis services within these areas. And therefore, the need for person-centered data monitoring is necessarily to track people living with chronic viral hepatitis over time and support case management. We should be able to track viral hepatitis so that these systems are able to generate data to track the health over time, to look at the track of the epidemic over time, but also ensures that we measure the progress of our programs. It's only when we have person-centered data that we can effectively monitor the programs, but also look at the health of a person across different spectrum. And the need to use person-centered monitoring is key so that data is collected only once and used many times across different platforms to minimize the workload in different cadres, but also to ensure that a person can access the same care and can be able to access the historical information, whether they choose to shift from one health center to another. So the shift is from looking at services delivered, but rather how do this service improve the health of a person? So not looking only at number of tests provided, but only looking at the number of people who have been diagnosed with hepatitis and linked into care. And this can be facilitated by using person-centered data systems within our health services. So as countries are planning to implement person-centered patient monitoring, it's important that we take stock on where we are and what is the capacity of our systems to be able to capture this data. We understand as different countries at different stages, it's important to understand what are the key questions to ask to relate to what our program needs to answer. For instance, we need to understand what are the indicators that our programs need to consider and the disaggregations for these indicators. They are core indicators, but there are also additional indicators that the countries may wish to monitor as they track their progress towards viral hepatitis elimination. It is also important to understand what are the data sources that are available in the countries to monitor the epidemic, and whether these data sources can be connected to be able to triangulate the information as possible. And as you'll hear from our speakers today, looking at different areas, tracking testing and treatment, but also tracking sequelae of hepatitis, linking data from persons diagnosed with hepatitis versus what is being captured in that vital registration, in particular death registry, to be able to allow the sources of data to be connected and triangulate the information to estimate mortality. Again, countries would want to understand the data systems that are needed, if the funding is available, and if the sources of the data systems can be ensured over time, so that even if the funding for particular data systems is not externally funded, we do have domestic funds to sustain the data system for collecting this information. Also, issues of data management and quality assurance over time, and understand what are the processes of the capacity to triangulate this information and involve all the stakeholders needed along the continuum of care for our patients. So putting into perspective, what we recommend has a stepwise process for implementing country surveillance. It's first using the data that is available. In areas where we do not have person-centered data system in place, we do know that data on hepatitis is available, and most of this is available in point of services, be it in tertiary hospital, where we have information of patients who have been diagnosed with hepatitis, treated or on treatment, and also from sources such as pharmaceutical records looking at available drugs and the use of drugs in the country for treatment of viral hepatitis. However, it is only when we use this data from multiple sources, look at it and highlight the inconsistencies and use it, that is when we can really understand the gaps we have in the country. So in our last webinar, we did talk about the global reporting, but what the global reporting is actually a platform where we ask countries to look at the available data sources within their countries. And some of this data is made available from different partners who estimate the cascade of hepatitis as well as mortality for hepatitis. So looking at this data and using it to guide our programs, and then needs to fill different gaps where the need be. And for this, and for today, we'll look at the next stages where countries are recommended then to set up person-centered data systems within countries to monitor routine data coming from facilities, but also looking at outcomes of viral hepatitis over time. So each step, depending on where the country is, but again, it begins by using the data that is already available within countries. And building on from what I just said is, and what will be presented today is looking at different angles of person-centered data monitoring. First, looking at what we can do to monitor data at facilities, looking at from treatment, from testing, treatment, and cure, but also looking at mortality. So our presenters today will focus on two of these. First, our first presenter will talk about DHIS2 and how DHIS2 can be used to collect and share essential information on hepatitis across multiple health facilities. Our presenter will talk about how they have done this in Rwanda, linking data from multiple sources and use it to really to move from using aggregated data to person-centered or individual level data that is integrated across different health actors, but also helped to help clients or patients to be able to monitor their health. And our second presenter will look at the different angle on where we can set up facilities to look at mortality information, looking at areas where patients are treated for hepatitis sequelae, that is hepatocellular carcinoma, as well as liver cirrhosis, and use this information to be able to estimate mortality for viral hepatitis. As you may be aware, already we do have sentinel facilities monitoring, for instance, drug resistance in HIV. But for this, in the sense of hepatitis, we are advocating for sentinel surveillance for monitoring hepatitis sequelae, and in the nearest future, also looking at drug resistance related to hepatitis drugs. And I would like to end my presentation by noting that we will be updating our guidelines this year to provide further guidance on strategic information for building person-centered data on viral hepatitis. And we're doing this understanding that many countries have invested in electronic medical systems and the use of unique identifiers and their use in the health sectors. But there's a gap on how this can be better used to further improve the performance of hepatitis programs. And therefore, our guidelines will be providing guidance on how we can use digital health to monitor hepatitis care and be able to consolidate all our recommendations, including the RMNE framework, as well as the various targets for eliminations, and provide guidance on how we can better how we can select the minimum set of indicators across different targets and indicators and monitor them at different continuum of care for persons receiving care for viral hepatitis. I would like to stop here and hand over to our next presenter, who will dive in deeper to looking at how this has been implemented in Rwanda. And for that purpose, I'd like to welcome and introduce Dr. Janvier Seremundo, who is the director at the Rwanda Biomedical Center in Kigali, Rwanda, and he will be speaking to us on how Rwanda has taken a step further to really introduce DHIS2 to capture individual level data from various facilities and integrate them to improve performance of the program. Over to you, Dr. Janvier, and welcome.
Thank you very much for the floor. Distinguished guests, ladies and gentlemen, good morning, good afternoon. I'm glad to share Rwanda's experience on how we integrated hepatitis module in DHIS2 for hepatitis data management. Next. This presentation will have 5 main chapters. First of all, a general background on Rwanda viral hepatitis program, then a specific background on data management, the DHIS2 rollout and implementation as the heart of this presentation, then our challenges, and lastly, conclusion and next steps. Next. As a general background on Rwanda hepatitis program, all kicked off in 2014 by the creation of hepatitis unit by the Ministry of Health. Then hepatitis guidelines were developed and a screening was initiated in few health facilities. In 2015, national policy and national operation plan were adopted, and the first patient was treated for HCV. In 2017, mass screening campaigns have been initiated across the country, and the first phase was dedicated to high-risk groups, including healthcare workers, PLHIV, people aged 45 years and above, genocide survivors, prisoners, female sex workers, and so on. Then the second phase was dedicated to the general population, the rest of the population. And we continued with that approach, and we ended up launching HCV elimination plan in 2018. The plan aimed to screen 7 million people aged 15 years and above during a period of 5 years. Now we are extending the period maybe, and we will reach elimination targets in 2030. And then as the government was committed to support this initiative, many partners, other governments were strongly engaged to support the initiative, and it allowed us to procure a large number of tests and medicines for the population in need. On top of that, all the services, including testing and treatment for hepatitis management, were free of charge for all Rwandans. Based on the amount of data that was being produced at that time due to the mass screening campaigns, then we thought of putting in place a system for data collection. Then at that time, we initiated an aggregated module of the DHIS2. In 2020, then we improved our DHIS2, and it was a DHIS2 tracker, which was capturing individual data. Then we decentralized our services to all public health facilities across the country, and then we implemented task sharing from doctors to nurses. Next. Obviously, it's been a long journey, and in the beginning, we were using a paper-based system. And then progressively, we moved to an intermediate solution, the Excel sheet, for example. And then lastly, we moved to the DHIS2. Next. From 2015 to 2017, we are using a paper-based data collection system, and all the information was collected using forms or registers. And towards the end of 2017, that's when we started to use Excel sheets. And then you can imagine the amount of emails that we were receiving from almost 50 hospitals, and it was not easy to compile that amount of data. That's why we thought of putting in place the DHIS2 aggregated module in 2018. And it was really helpful because we were able to generate routine reports. And the reports, the indicators were routinely collected on a monthly basis. In 2020, as said, that's when we put in place a DHIS2 tracker for individual data collection. Then we were able to have real-time reports and dashboards. And an important component was the SMS, especially for notification of patients about their results, or about any drugs refill, any appointment, then the SMS component was really important next. Next. So practically, we have different stages when we are entering data in DHIS2. Then there is a phase of enrollment when we enter demographic data of the patients in the system. And then there is a stage when we are entering screening data. And then when the screening test is positive, then there is a collection of viral load test. When the viral load test is positive, then there is a result which is entered in the system, and an SMS is generated and sent to the patient, telling him or her to come to the health facility for treatment initiation. For negative also patients, an SMS is sent in that sense as well. Then there is a treatment, a follow-up, whatever can be done for HBV or HCV. And then the final stage, especially for HCV, is the confirmation of cure. Next. So this is an extract of our system. It's a web page. Then we have the registration stage, the enrollment with the profile with all the demographic information. And then we have the screening stage. You can see that on this page, we are able to identify
Dr. Janvier, can you still hear us? I think you seem to be frozen. Do we know how many slides are left?
A lot.
Five, but it's fine.
She must have dropped off. Is possibly going to join again.
Is Dr. Janvier still with us?
No, he's not.
Okay.
Maybe should we bring in Catherine and come back to the end of his presentation, or still? Here he is. Dr. Janvier, you're back. Sorry, you were frozen, and unmute yourself. And
yeah, I have been disconnected for a while.
Okay.
So the next slide on viral load, please. Yes, after the screening stage, we enter the viral load information. And then when the result is available, it's entered in the system, and an SMS is automatically generated and sent to the patient for information, for requesting the patient to come to the health facility for treatment initiation and further follow-up. Next. We have pages also for pre-treatment assessment and treatment outcome. So the pre-treatment assessment is mainly the liver function evaluation and renal function evaluation. And then the treatment outcome, as you can see, we have the keyword, the treatment discontinuation, the treatment failure, the loss to follow-up, and the death if a patient may die. Next. So on top of what has been said, in summary, we have many advantages from the use of the DHIS2. And it allowed us to have real-time data visualization, an easy monitoring and evaluation of the program, timely reports, and then a permanent storage of timely retrievable data, just as a proof of the work performance. As said, in addition, we had an SMS component, which was really helpful for patient information and prevented the loss to follow-up of patients who may be positive and delay to come for treatment initiation. Next. So on top of what we had as advantages, we can't ignore some hiccups, some challenges that we had with the system. In the beginning, we had a double recording. People were resistant to use the new system. You know, there is always a resistance to change. And a part of the healthcare providers were using paper exclusively and refused to go to move to the new system. Another part of them were using both paper and electronic systems, and maybe they feared that the system may fail, and then they don't have any backup. In the end, we were having a double recording, a waste of time. It was time consuming, but progressively we conducted trainings, mentorships, and then we succeeded to change their minds, and then they were able to adopt the new system. Another challenge was the coexistence of other systems, and then the DHIS2 was perceived as an additional burden for the healthcare providers because it was time consuming, and with other systems, it was so hard. Another challenge was just the acquisition of the culture of recording. As healthcare providers were using manual system for decades, then it was so difficult to move to an electronic system, but the culture has been acquired progressively. The last challenge was the data quality. In the beginning, obviously, they were filling in the information and some data were incomplete, but with an intensive mentorship, working with them in front of the patient, and the data quality has been progressively improved. Next. So as a conclusion, Rwanda's experience shows that we need multiple strategies to ensure a successful rollout of any electronic system. For Rwanda, we have implemented trainings of healthcare providers, data managers, nurses, lab techs, doctors, whoever can use the system. And then most importantly, we trained trainers of trainers so that they can continuously train others, but also mentor them regarding the use of the systems. We also conduct continuous mentorships, and then we do site visits to different health facilities, and we work together with healthcare providers on the system. The last one is that the system needs a dedication of resources for its design, for its use, and its uptake. So the resources include human resource, the trainings, the continuous mentorships, motivations, but also equipment. For example, we have procured tablets, and they have been distributed to all health facilities across the country so that they can facilitate the use of the system. We need internet connection. We need also the system to be user-friendly so that it can be easily used by the end users. So we need to know the user preferences so that we can continuously customize the system features. Next. So as our next steps, we are continuing to enhance ADHIS2 features by incorporating new hepatitis management components. We are working on the interoperability with other systems such as the CRVS, Civil Registration and Vital Statistics, the system which is being used for the registration of death, and then the cancer registry. We are continuously performing data quality checks for an improved data completion and for further validation for elimination. Thank you very much for your attention. Apologies for any disappointment. The internet was cut off. So the floor is open for questions and comment. Thank you.
Thank you very much, Janvier. Dr. Janvier, that was a very comprehensive presentation. We will move to the next presentation, and you have already one question in the chat if you want to look at it, and we can discuss it in the Q&A in like 10 or 15 minutes as well. So next slide. I think you made a very good case for the introduction of DHIS, and I'm sure other country colleagues have some questions. I'm very happy and proud to introduce now Catherine de Martel, who is a colleague and scientist at the IARC, the affiliated institution to WHO. Catherine is a very experienced scientist with regards to mortality of hepatitis B and C, and she will talk to approaches to estimate hepatitis mortality at the country level. I will just say hello as well in French, because Catherine is as well from France, and there might be French speakers online. On souhaite le bienvenue à Catherine de Martel de l'IARC.
Welcome to Catherine de Martel, a colleague and scientist working on hepatitis mortality. Please feel free to ask your questions in the chat in English or in French, as we will get back to these questions at the end of the session in the Q&A session. Thank you. The floor is yours, Catherine.
Merci, Nicolas, pour cette introduction.
Thank you, Nicolas, for the introduction.
Et bonjour à tous les francophones, and hello to all English speakers online. I'm very happy to be here today. I will try to be quick because we are already a little bit late. Next slide. So the context, as you know, the World Health Assembly called in 2016 for not only for testing and treatment, but for elimination of viral hepatitis as a public health threat. This, as Funmi reminded us in the introduction, 1.5 million persons die every year from the consequences of viral hepatitis, and more than 90% of this mortality is due to cirrhosis and hepatocellular carcinoma. Next slide. And mortality is an impact indicator used by WHO to define if a country has achieved elimination. So at first it was relative targets, 65% reduction compared to the baseline in 2015, but because most countries don't have a baseline and relative targets have been changed to absolute targets, which were set up at first to 4 per 100,000 for B and to 2 per 100,000 for C. And we're talking about mortality per 100,000 people. But the updated guidance now recommend or suggest, if you want, to use a common threshold of 6 per 100,000 population for both viruses combined. So this means that even if the country focuses the elimination toward just one virus, for instance, C, it is now recommended to monitor mortality from both viruses. Next slide. And it makes sense. The general method to estimate mortality from HBV and HCV infection is a two-step approach. One, to estimate the mortality envelope, which is the total number of deaths from cirrhosis in 1 year, plus the total number of deaths from HCC in 1 year. And the second step is to estimate the etiological fraction, meaning what is the proportion of people who had late-stage cirrhosis or late-stage HCC from HBV and from HCV, and who died from it. And then you put the previous slide, please. Then you put the two number together and you can calculate the number of deaths from HBV and HCV infection. Next slide. So as you know, the mortality envelope is usually derived from vital statistic. And we have to remind ourselves that death certificate considers a sequence of causal events. And what is really reported when you use ICD-10 coding is the underlying cause of disease, which can be cirrhosis and is rarely hepatitis B and C. And sometimes, next slide. Next slide. So there are some limitations to use vital statistics and the mortality envelope derived from vital statistics to calculate the mortality. Because patients dying with HCC and decompensated cirrhosis are difficult to assign to one of the two diseases. The clinical manifestation of the disease are multiple and they may mask the real cause of death. So sometimes the underlying cause that is coded is infection or can be hemorrhage or bleeding, and cirrhosis is not coded as the underlying cause of death. And there are many other reasons that I won't go through, but the mortality envelope through vital statistics has many limitations, and some may be overcome by moving from the coding from ICD-10 to ICD-11, because ICD-11 coding could solve some of these problems. Next slide. So I have talked very briefly about the mortality envelope that is derived from mortal statistic at the country level. Now I will talk about the etiological fraction, how to estimate this. Next slide. In many countries, to estimate the etiological fraction in patients with cirrhosis or in HCC, what is currently done is to use vital statistics again, because ideally, those vital statistics will capture the underlying cause as being HBV infection or HCV infection. And the use of ICD-11, which prompt to code also the etiological factors, will help to get this information on etiological cause of cirrhosis and HCC. But in other countries, what is done is to use large surveys of the prevalence of HBV or HCV in the general population, and then through some statistical modeling to estimate the etiological fraction in patients with HCC and cirrhosis. But the problem of this approach is that there is a long latency period, so you need complex assumption to do that and many statistical correction. Also, those large population surveys, they are very costly, and they cannot be done many times. And these surveys are not ideal to capture key population. So vital statistic, large surveys are some mean to monitor etiological fraction, but they need to be checked using other sources for consistency of the above estimate. And if you look at the last line of this slide, all these approaches take time or are difficult to implement. So if we want to measure mortality and have a good measurement of mortality now, what should we do? Something easy and easy to implement. Next slide. So what WHO is recommending right now is to use Sentinel Centers surveillance approach. And we developed a protocol. It was first a very full and complex protocol. Now it's a very simplified template protocol, which is available to you and can be adapted to your specific national settings. And it's very easy protocol. First, you have to carefully select several representative centers, hospital, clinics that routinely see patients with liver disease and are going to represent all the differences of epidemiology seen in your country. For instance, the prevalence of HBV can be higher in the south than in the north, or inversely. Or some population at risk might be more present in some area or some city. So you really want to capture everybody. So get several representative centers. The precedent slide, sorry. Previous slide, please. No, previous, thank you. And then you have to, no, next. Sorry. Next. Next. No, you're going backward. So next. Yes, perfect. No, previous. I'm sorry for that. Je suis désolée pour ça. La previous one, please. Yes, perfect. So the first step is to carefully select several representative centers. The second step is to identify in these centers all consecutive patients with decompensated cirrhosis and HCC over a predefined period of time. And the third step is to extract from these patients the proportion of patients with HBV and HCV infection, and also other etiological factors, and then to make sure to be able to repeat this exercise periodically, for instance, every 2 years. Next slide. Thank you. So this is an example of the case report form, which is very simplified and has only 4 sections: a section on ID of the patients, sequelae, exposure, and other risk factors. It collects information on decompensated cirrhosis and not on compensated cirrhosis as previously done in the previous protocol. The case definitions are adapted as per country guidelines. Only relevant laboratory diagnoses are included, and only relevant other risk factors are included. Next slide. So in summary, the recommended method to estimate the mortality from HBV and HCV infection is what we call the double barrel approach. First, to improve the mortality envelope with accurate measurement via death statistics of total deaths from cirrhosis and HCC. And second, to measure accurately and now etiological fraction from several sentinel centers that are representative of what is going on in your country. And you combine the two statistics and you will get the number of deaths for HBV and HCV infection that is quite accurate and a representative of what is going on right now. So in conclusion, next slide. The pledge for hepatitis elimination is based on a mortality target that needs to be measured in a reliable way, ideally for both viruses. Now that needs to originate from countries and not to be calculated, but by some institution outside the country, because countries need to measure their progress over time. And ultimately, the improvement of mortality statistics should allow direct measurement of mortality due to hepatitis B and C, but this improvement will take time. So in the meantime, we recommend measuring and monitoring hepatitis mortality as a double barrel exercise, improving vital registration, and consider moving toward ICD-11, and measuring and monitoring the proportion of cirrhosis and HCC in sentinel centers with the use of the WHO simplified template protocol. And I think it was my last slide. Thank you very much. Merci beaucoup. And sorry for the technical issues. Merci.
Merci à toi, Catherine, pour cette formidable présentation.
Thank you, Catherine, for this presentation.
So we're going to a Q&A session. I think we will start with your questions that we have seen in the chat. And please bring out other questions. Raise your hand. Don't be shy. Don't be hesitant. We can all learn from each other. We know that you have a lot of experience. And we will then have a couple of poll questions as well before I hand over to Dr. Lacey again to close us out. But we have a good amount of time for discussion, really almost 20 minutes, I believe. Umesh, we saw your comment and or question, maybe please come in and talk about your comment. Is it maybe let us know if it's a question to our team as well, or if you just wanted to share that important point about disaggregating data for different population groups. Thanks, Umesh from Chai. Please unmute yourself. You can't talk.
I think Echo needs to unmute him.
Ah. Can you unmute Umesh from Echo Central? He doesn't seem to be. Well, while you're unmuting, Janvier, can you, Wasim had a nice question. I know you answered already. He was asking who's entering the data. Maybe just bring in the question and the response as well quickly to the audience. Thanks.
Yeah, thank you very much. In the beginning, doctors were consulting patients that it was in 2020 when we put in place a task sharing from doctors to nurses. And then the tasks were shared to nurses. From that time, nurses are consulting patients and they have been trained on DHIS to use, and then they can easily enter all patient information in the system in the real time when the patient is with him or her. And then for complicated patients, complicated cases, a nurse refers to a doctor, that patient, and then they work together, but the information is already entered by the nurse in the system. The role of data managers are just they are just supervising the activity. They have, a big role of coordinating, as they are supposed to have more knowledge. Then when we have some problems, when we have some electronic system downtimes, then they can intervene, as they have been trained as stewardesses, and then they usually assist other healthcare providers in that sense. Thank you.
Thanks, Dr. Janvier. And I see as well, this question came from a colleague from MSF in Bangladesh, and they want to go into an electronic-based system as well. I think you made a very strong case, Dr. Janvier, about the advantages of going from the Excel to the more, digital or electronic-based versions. That was very good. Now Umesh is unmuted, but before you come in, Umesh, I will just say that I would like to have as well our Armenian colleague from the Republic of Armenia that said that they are building a system come after you. I don't know if he needs to be unmuted as well. Dr. Narina, she or he can share a little bit about the system that they are building for hepatitis in Armenia. So Umesh, please highlight your points.
Thank you, Nicholas. Can you hear me?
Yes.
First, I would really like to thank WHO, Dr. Diana, our representative from Ministry of Health, Rwanda, Dr. Sorando, and Dr. Catherine for their lovely presentation and very informative sessions. Thank you very much. My question comes from the fact that how are we using data to understand that are we able to cover the key and priority population in your respective regions and countries, while we understand that the prevalence of hepatitis C as well as hepatitis B is higher among key population as well as priority population that can be contextualized to the respective countries. How are we, recording the data, and how is the program responding to the need in case some of these key populations are being left out because of various reasons that we all understand? And is this in any way a part of perhaps country context, even at global level for WHO to highlight on, is how are we going to measure the epidemiology and coverage for key populations across? Because that is something that we are really struggling to understand. I do understand particularly that they amount to a fraction of the total prevalence of hepatitis C and B. However, due to their nature and they are most likely to be left out. Thank you very much.
Okay, thanks, Umesh. I will ask Diana Finey from our team to give a first answer, and we can see if we want Dr. Janvier, for example, to complement.
Yes, thank you, Nicholas, and thank you, Umesh. And I think he did mention it, and I think the question is, what are the best indicators to describe a program? And it comes down to understanding what your epidemic is, and therefore your the response, which is very context-based, as you mentioned, has a country needing to understand where the next further infection is going to occur, because we don't want a system that is tracking the epidemic in one population, leaving out a priority or a key population that is mostly affected. And the priority of key populations is different according to different contexts. For instance, in PAO, we want to look at, for instance, race, because we know the epidemic is different in other areas. For instance, in the Euro region, we want to be sure we also monitor the infections among immigrants and not only people who inject drugs. And the context defines this. For instance, perhaps in Rwanda, they want to monitor genocide survivors because that is the drivers of the epidemic. So the priority and key populations differ in different contexts. And we want systems that collect indicators in a distributed manner so that services are provided in an equitable manner to cover those who are most at risk and most affected. So it is context-based, based on the drivers of the epidemic in the population, but of course, understanding that some key populations are uniform across different areas. For instance, people who inject drugs are most at risk of HCV. So it will be very important for programs, viral hepatitis programs, to include a disaggregation on people who inject drugs within the minimum data set, and include that as part of the indicators that is constantly monitored within their programs. I'm not sure if I've completely covered it, but perhaps Jean-Pierre can add to it as they have done in Rwanda.
No, I think that's very good. I don't know, Dr.
Thank you very much. I think the response was comprehensive and almost complete. Maybe what I can add, what we did in Rwanda, in the beginning, we defined our high-risk groups. Obviously, we have universally defined key populations, but for Rwanda specifically, we defined our high-risk groups because people aged 45 years and above, for example, it's not a commonly known high-risk group. But it was just based on the context of Rwanda that traditionally people were just using sharing blood as part of the culture. And then it was a high risk for HCV infection, traditional injections, and so on. So we defined our high risk groups, genocide survivors, prisoners, female sex workers, MSM, and so on. And then we were just visiting each category so that we define them and then we can reach out to them easily. And then we started the screening in that specific category. We are able to have prevalences from each of the categories. And then after that stage, we moved to the general population. For the general population as well, we mapped the different districts of the country, and we were just screening different districts, and some districts were we are having a high prevalence more than others, and then we moved on with focusing on districts with high prevalences until a time that the prevalences were almost similar in all the districts. Over.
Okay, thank you, Dr. Janvier. I think that's very comprehensive in addition to what Dr. Fani said. I hope we addressed your question. You're still unmuted, Umesh, but please keep it short so we can bring in some other people.
Just one follow-up comment, Nicholas, and I would mute myself. I'm saying that because even in the global reporting for hepatitis, we are not really asking for these indicators. Quite a few countries, and I really would like to comment on Dr. Soromando's the strategic approach that Rwanda had on segregating its population, but then that needs to be also reflected globally in the data that we have. And perhaps the data is already there, but it's not that easily or publicly available. So if the global reporting format by WHO, it does not require countries to report on key population and priority population, there may be a chance of countries missing out on that data. And for us to actually understand that progress made towards populations that are likely to be left behind is also taken care of. Thank you, Nicholas, and thank you everyone for responding to my questions.
That's a good comment. I think maybe Diana wants to say something about global reporting and disaggregation later. I would as well highlight the comment from our colleague Anton Smozalewski, who says that while that disaggregation is very important, that there's criminalized populations often, and that it's crucial, to ensure data safety and confidentiality. I think we're soon moving to the poll questions, but I wanted to see if our colleague from the Republic of Armenia, Dr. Narina, wanted to share a little bit how they're building the hepatitis reporting system that they're now building up. Dr. Narina, thanks for joining.
Hello to everyone. Yes, because the data on viral hepatitis, on mortality, cirrhosis, hepatocellular carcinoma is so fragmented in our country. We understand the importance of have a national register of viral hepatitis, and the process started in 2022 with support of WHO, and this system is rely on WHO Excel file format for data accumulation. And as I mentioned, it's very comprehensive. It's includes a lot of data. We have some more information on epidemiology of viral hepatitis. And up to the end of this month, we stakeholders and Ministry of Health decide to finally discuss all important information on who should fill the data and information in register on different levels. And up to the end of this year, we plan to implement it. Thank you.
Narina, Dr. Narina, that is thank you for sharing that, because I think that shows again the importance, and it will be a huge step forward for understanding the response better and monitoring the response in Armenia as well. So that's a very important piece of work, and thanks for sharing that. I think I will hand now over to my colleagues. We've prepared some poll questions. I would say before I do that as well, we have pasted in the chat 2 questions on mortality. What are the challenges that you may encounter? And then a second one, it's just a little bit higher up in the chat. If you think that the implementation of the WHO simplified protocol is, let's say, feasible and relevant to your country. If you feel you could respond those in the chat, that would be helpful for us. You can see them higher up. And I hand over to Sandy and Diana for some poll questions. Please engage in the poll questions as good as you can.
Thank you, Nicholas. And we have prepared a few poll questions to keep us into the discussions of today's session. Our first poll question is asking whether there's a national electronic data system in your country that is used for reporting patient level viral hepatitis data, that is hepatitis B or C testing and treatment information. And we would want to know if this is a countrywide electronic data system. And we understand that there may be other data systems that are not networked across different health facilities. So option 1, yes, there's a countrywide electronic data system. And if possible, kindly mention it in the chat. Option 2, no, electronic patient medical records exist in hospitals or other point of services, but not networked nationally. Option 3, there are no electronic data system that exists, and D is I don't know. So we have had, with looking at responses coming in, and only 9 participants have participated. Would like you to please go ahead and post your response. Thank you for all those who are taking the polls, and we will close the polls soon so as to go to the next question. Thank you. We do have responses from 26% of the participants. If we could get some few more seconds to complete this and move to the next. So we see that half of the respondents do have some sort of electronic data system. If we could end the poll here, please, and share the results. Please share the results. No, they're not seeing it. Okay. So yes, 47% do have a country-wide electronic data system that is available. 16% do have some form of electronic patient medical record, but are not networked across the countries. And 37% do not have an electronic data system in the country. Thank you all for taking part in the poll questions. We now move on to the second question. So the second question is asking if your country is currently using DHIS2 specifically for hepatitis data, that is, if you do have hepatitis module within the DHIS2 system that you're using. The first option is yes, DHIS2 is available in the country. Sorry, the first option is DHIS2 is not used in the country. B, DHIS2 is used, but does not include hepatitis module. C, yes, DHIS2 is used for reporting hepatitis data, and D is I do not know. Thank you all for those participating into the polls. We have 31% response, and most countries do, from those responding, do have DHIS2, and they are using it for recording hepatitis data. We're giving a few more seconds to complete the poll and move on to the next question. We'll end the poll here and share the results, please. So there is some sort of a DHIS2 system in most of the response, but in some, DHIS2 is not used. Hepatitis module is not included in the DHIS2, but we do have 32% saying that they are using DHIS2 and are having a hepatitis module within the DHIS2. I'll hand over to Catherine now to take us through the remaining poll questions, and please do post it in the chat on any comments from your responses. Thank you.
So next poll question, please. So the next poll question is about the International Disease Classification System. To your knowledge, what version of the ICD is currently used in your country? Is it still ICD-10? Is it already ICD-11? Or are you in between? Your country is transitioning from ICD-10 to ICD-11, or you don't know? So A, ICD-10, B, ICD-11, C, my country is transitioning from ICD-10 to ICD-11, or D, I don't know. We're still allowing a few seconds to close the poll. Okay, let's close the poll. We have now 45% of people who participated, and the answer is that either people don't know, which is a vast majority, but many people still are in ICD-10, and some 22% are transitioning from ICD-10 to ICD-11. So thank you for this information, which is very interesting to us. Next poll question. So the fourth poll question. Next slide. In your country, what do you think is the main data source to estimate the total number of deaths from cirrhosis and liver cancer? And we are talking about the mortality envelope, the total number of deaths from cirrhosis and liver cancer. So national response A, national vital statistics and death registration. Response B, linkage with hospital data. Response C, country-specific data modeled by an external group, for instance, the Global Burden of Disease, which is IHME, or the Polaris Observatory, or IARC. Or response D, I don't know. So we'll allow a few more seconds. And we can close the poll now. We have almost 20% responding, and the vast majority says that the main data source to estimate the total number of deaths is the National Vital Statistics or death registration. While 21% of the respondents say that they use country-specific data that are being modeled by an external group, and a few use linkage with hospital data. Thank you very much for this information. It's very important and relevant to our work. So next poll question, this is the last one, poll question number 5. Next slide and poll, thank you. So how do you think your country is currently able to provide estimate of the total number of deaths from viral hepatitis? So not the mortality envelope, but really the deaths that are coming from viral hepatitis. So the answer A is National Vital Statistics alone. Response B is representative large cohort studies or national database of patients with vital hepatitis. Response C is National Vital Statistics corrected or enriched by expert opinions. Response D is National Vital Statistics coupled with an independent measure, either internal, for instance, through Sentinel surveys, or external through global meta-analysis. And response E, I don't know. So this is a complex question, so I will allow for a few more seconds to respond. We have seen that some countries have national databases of patients with viral hepatitis, but they are still not totally active and able to be coupled. We are going to stop the poll now. So the majority of respondents say that they are relying on National Vital Statistic alone, which I hope I show today can be a problem because they don't capture accurately Hep B and Hep C mortality. And then some more rely on expert opinion, which can also be a problem because expert opinion are sometimes biased. And then some rely on National Vital Statistics, but use independent measure of etiological fraction. So thank you very much. Again, it is very useful for us to know all this information from you. Thank you. So I think we can end the poll. Thank you again. Merci beaucoup.
Okay, thank you very much. And before I actually start to say thank you, I'm interested in what all the participants think about the simplified monitoring of mortality. And I would like you to put in the chart if your country is interested in digging a little bit deeper into mortality surveillance, and if we can have a separate seminar to maybe provide technical support for countries that may be interested in pursuing or strengthening their mortality. So kindly write this in the chat and we will communicate with you later with Dr. Catherine taking the lead in this. Maybe I'll give you a few minutes to please just put your name and your country in the chat and we can reach out to you before the end of the week as we plan this session. Thank you very much. I see 61 participants and no comments in the chat. Okay, now I see some comments in the chat. So let us know if your country is interested to take mortality to a higher level and support sentinel surveillance with the appropriate personnel and the appropriate people in the countries, because we understand that there are different departments that do this. All right, so I think we've had a really excellent, thank you very much, South Africa. I see the country, thank you. We've had an excellent and insightful dialogue today. And you know what, there are some key take-home messages for viral hepatitis data, including promoting people-centered reporting. And the example from Rwanda was really key. We saw the evolution of the information system from paper-based to digital to DHIS, and a progressive integration across national information systems. We also highlighted the importance of disaggregation of data. Of course, we have standardized global disaggregation, but some countries may want some specific groups in addition to the standardized global reporting. As we close, I want to thank the expert presenters for the very, very stimulating presentations, exciting presentations, the interactive discussions, and the engaged participants. As we close, also, we really appreciate the ECHO team who are really committed to supporting us every month, and the WHO staff members from headquarters, from the regions, for the countries. And just to mention that the recordings, the presentations will be shared with everyone so that we can have access to them. So thank you very much. I also see some people are interested in DHIS2, and again, we would reach out to people interested in DHIS2 as well as mortality. And on this note, I would like to thank everyone. And maybe one last question is, we are trying to plan this agenda to meet your needs and to meet the needs of participants. So if there are any topics you would like for us to consider for future webinars, kindly again type them in the chat. I think we're wrapping up now, but I know the platform will be open for another 5 to 10 minutes. So help us to develop an agenda that reaches you, that meets the needs in the country for viral hepatitis. So again, type in the chat topics that are not necessarily data, maybe PMTCT, but what do you want to hear in the next couple of months? What are you interested in, or what country aspect would you particularly like to share in upcoming seminars? Then we can give you 10 minutes and a presentation to share your successes, your experiences, your challenges, and your solutions as well. So again, type that in the chat so that the chat becomes a rich source of reference for us as we co-design going forward. Thank you very much and have a lovely day ahead. Okay, so it says also there's a feedback survey. Please fill that feedback survey before you leave. So on behalf of all of us in the room and our committed participants, we are really pleased at the outcomes of our meetings, and we hope to make ongoing impact in countries for viral hepatitis elimination. Thank you, have a great day ahead, and bye.
Thank you.
I can't see the chat.